Okay, we were learning about the antiarrhythmic drugs. So we'll go about the introduction part of this antiarrhythmic drugs are concerned. Yes, the drugs used to prevent the heart irregularities are called as the antiarrhythmic. And after the episode of Mr. Puneet Rajkumar, everybody is worried about the heart. So now this topic has gained a lot of importance, so that the drugs used to prevent the treat the irregularities in cardiac rhythm. Whenever there is a two types of the drugs are there. One is the cardiac arrest and cardiac arrhythmia, and the congestive heart failure and pneumonia are there. So
the extension box is there.
Then the cardiac arrhythmia is producing the abnormality in the heart rate. Then especially irregularity in the heart beat. So heart rate, heart beat irregularities, and also the sometimes the force of the conduction of the cardiac impulses and filling up of the ventricles by the auricles, and also the relationship between the myocardial contractility. So we have learned all these things in the previous class. Anyway, there is a lot of gap between the earlier class and this thing, so we will try to cover up very fast. So the factors included in the cardiac arrhythmia are: number one is these myocardial diseases, especially which are affecting the contractions of the muscle fibers, and the CNS diseases. So the CNS disease, how it is going to affect is, the number one is especially the vagus nerve. Vagus nerve, it is going to have the branches to the heart. At the same time, the vagus nerve is also having the varieties of the branches to the ear, etc. Then whenever there is a CNS disorders are there, then the vagus nerve gets stimulated. So because of this thing, there is a problem, especially the arrhythmias. Then the renal failure also causes many varieties of the toxins to accumulate in the body. Then it also occurs. And the hypoxia, especially in certain toxicities like the toxicity of the many drugs, and also the mycotoxins which are affecting the heart. So this affects the oxygenation status, especially you have learned about the cyanide toxicity. So that is also going to affect the oxygen content in the blood and which is supplying to the heart. And the myocardial ischemia, especially the coronary arteries which have three branches and supplying to different parts of the heart. So that's also what it causes. And whenever there is a this blockage in these coronary arteries, then it causes the myocardial ischemia or the necrosis of certain part of the heart. And at that time, there is a decreased blood supply, and the person will get the angina pectoris, means cardiac pain or palpitation. And this infarction of cardiac muscles means the necrosis of the cardiac muscles. So it's also an important factor. Many times this hypoxia may lead to ischemia, then this may lead to infarction of the cardiac muscles. Then some of the cardiotoxic substances already are learned about the digital galactosides and the nerium oleander and many more cardiotoxins. And the adrenal or thyroid disease, of course, nowadays we have already discussed that it is an undiagnosed disease which is causing a lot of problems, especially at the heart is concerned. Then excessive sensitivity to autonomic regulations, maybe the blood pressure regulations. If there is a continuous blood pressure, the cardiac muscle gets loosened, and that causes the autonomic nervous system, especially the both parasympathetic and sympathetic nervous system, to control the heart rate. And the mechanical trauma, direct injury, bike accidents, then sometimes the heat, etc. They are going to cause the mechanical trauma. Then changes in serum pH and electrolyte balance, whenever the animal is suffering from especially the lactic acidosis is one of the important thing, and that causes the change in the pH. There is a pH decrease in the blood. It causes the cardiac arrhythmia, and also the electrolyte imbalance, maybe hyperkalemia or hypernatremia, will cause severe problems in the heart. And excessive stretching of the cardiac tissues, yes, this was said to be the cause of death of Puneet Rajkumar. Excessive stretch of the cardiac tissues which led to cardiac arrest. Many times it may happen. And especially in case of cardiac arrest, if the person is not attended within 5 minutes of the stop of the heart, then he may not survive, because it requires very emergency treatment, whereas the other conditions, especially the blockage of this coronary arteries, it takes long time for the therapy, etc. And heart attack is totally different, and cardiac arrest. There are two terms are there. One is the cardiac arrest. Cardiac arrest. This is Puneet Rajkumar. Yes, died. Then another term I told is the heart attack. These are the layman terminology, heart attack. So this is especially the myocardial, especially the excessive stretching, etc. They are going to cause all these things. This cardiac arrest, whereas the heart attack is caused by so many factors. Not only one, that's coronary artery blockage and myocardial ischemia, and so many things. Because whenever there is a heart attack is there, so it will give a lot of the symptoms, especially the fatigue and pain, then sometimes the choking like symptoms, etc. Whereas the first one, that's the cardiac arrest, is acute in nature, suddenly it's going to happen. There may be a problem of the heart valves, etc. Then the sudden cardiac arrest will happen. So that's one of the things. And excessive stretching of the cardiac tissues, which happens nowadays. We do not know what are the scientific reasons between the death of these persons who go to gym and get this. So everybody is fearful, and the scientific research has to go on. Whether the stretching of the cardiac tissues too much with over exercise, etc. Especially the sports persons are also going to die very effectively, and lot of debates are going on, and we'll see, because you have to study, because this is a very correct time to study the cardiovascular pharmacology. Everybody's attention is to now. So yesterday I gave you both of you the assignment, especially. Ultimate purpose of this course is to apply your knowledge in the animal treatment. So whether the cardiac arrest is present in case of the animals, or sometimes the cardiac attacks are there, so we have to study whether the coronary block is there. Yesterday I think you are all studying, I think, and I also given you. So this is the correct time to study. So let us have a lot of importance to this thing, and of course you have learned all these things. The resting membrane potential in the heart, it's minus 8 millivolt, and the PQRST complex, SA node, AV node. Then, so the conduction of this action potential is from the SA node, then it goes to atrium, then AV node is Purkinje system, then it went to the ventricles. This is the cycle how it regularly generates. So here it is going to generate in the SA node, then it is conducted to the AV node, then this SA node, from atrium it will go to AV node, then this Purkinje system, then ventricle finally. So this is the complete heartbeat in the ECG pattern. This is going to be reflected. It's a lot of electrical changes are there. So the electrical changes which are happening in different systems, SA node, atrium, AV node, there is a little difference, because sometimes you can see that this is the ascending phase or phase 0. Then here the lot of sodium ion channels are suddenly they are going to open. Then the potassium ion channels and the slow calcium channels are going to open. Then the fast potassium channels are going to open. Then once again it goes to the resting membrane potential. This is the sequence of events, how it goes. So then this generates PQRS complex and T waves. So suppose if this is not normal, then the cardiac, especially the cardiologists are going to diagnose. There is a QRS complex will be inverted whenever there is a QRS this thing. Some ventricular contractions are not proper for CHF, so they are going to diagnose this thing. So ultimately, this is the output. This we are not going to drive this especially measure. So this is measured by the electrocardiography machine, which is one of the oldest thing, but still it is the most cheaper way of diagnosing the cardiac problems. So the mechanisms of the arrhythmias, we already there is a disturbance in impulse generation. Suppose SA node, there is a problem in impulse generation, then it is unable to transmit to the AV node and atrium and this particular system. So then these abnormal this anatomical of the SA node. That's also one of the problem. And the causes of this are due to the alteration in phase 4 of the deflorization. So you know phase 0, phase 1, phase 3. Phase 4, this is a deflorization, and here vagal stimulation or beta receptor blocking drugs flow normal pacemaker. So suddenly if you slap a person with your hand, especially below the eye ear, so the vagus nerve, 10th cranial nerve starts, then it is innervating the upper part of the trunk, then it's going to lower, supplies most of the gastric organs, especially inside this GIT system, and also supply to the heart, and also the genital organs in case of males and some women. So this is caused due to the alteration in phase 4, vagal stimulation or beta receptor. So the drugs, beta blocking agents we are going to use to decrease the blood pressure. So at that time, if you are using them what you call as indiscriminately, then definitely it is going to cause the pacemaker. Then acceleration of the pacemaker is SA node. Then by the hypokalemia, suddenly if you take this potassium containing drugs like potassium chloride etc., then the cardiac arrest happens. So that's one of the things. And potassium iodide etc., if you are administered fast IV, most of the drugs, if they are administered fast IV, then what happens? The acceleration of the pacemaker, then by hypokalemia or beta adrenergic stimulants. So sometimes the adrenaline, if you give fast IV also, it is going to cause the adrenal stimulation. Then, so these are all the reasons. Arrhythmia means rhythm is going to change. Rhythm means not only the rate of contraction, but also the force of contraction and the impulse generation and many more. So what happens, especially the enhanced automaticity in the latent pacemaker, is due to the spontaneous rhythm is taken by equation part of the heart. Means whenever the action potential starts, most of the heart is in quiescent state. Means it is happening within a fraction of 100 milliseconds or 400 milliseconds. So spontaneous rhythm it is required. Rhythm means one after the other. Or suppose the SA node is going to generate the action potential, it goes to the atrium, then ventricle, entire heart, and this principal Purkinje system. So here ectopic heart, sometimes the out of this especially normal position, the heart will be ectopic in small kids. So site of heart initiating a latent impulse means they were delayed impulse is also another problem. Then this all may result from block, especially the coronary arteries, nodal block or bundle brain block. So this is related to the blocks, especially this Purkinje system and bundle of his. So there will be a block and re-entry here. The usually circus movement, you have seen that there is a diagram that it enters then ends. So we'll see what is the circus movement. Re-entry means then conduction block or heart block. There are varieties of the block. And re-entry means one impulse re-enters and excites area of the heart more than once without need of the new impulse to be generated. Means first the impulse is generated in such a way that one area of the heart is excited, which excites the entire heart without the need of the new impulse. But in between, if there are newer impulses are there, then it causes the cardiac arrhythmia. So this is caused due to the imbalance of conduction velocity or refractory resistance cardiac tissue. So conduction velocity is increased or decreased, then refractory resistance. And some formula of re-entry are functional re-entry and anatomical re-entry. So we'll see. That's the whole Parkinson-White syndrome. We have seen that in the earlier class. So I think this is not clear. So here, generation of a re-entered rhythm by damaged area of the myocardium is going to enter. Usually, when a SA node starts the action potential, it has to end in the the ventricle. But what happens, instead of ending it, it is going to re-enter the circle. Means it is going to excite the SA node. That's why it causes the circus movement. Or here you can see this is a normal movement of the especially generated by one way and propagated by entire heart muscles and end. Whereas what happens whenever there is a anterior great impulse is blocked, maybe due to the cardiac block or the infarction. Then also the impulse may not properly conduct, or else there is a called as circus movement, means the action potential or the current generated will re-enter the heart and once again it disturbs the original place where the impulse is generated. That's why generation of the re-entrant rhythm, then it causes the ventricular fibrillation. That's what it causes. Okay. So this is the anatomical re-entry. Wolff Parkinson White syndrome means it is going to be generated on this, and here there is a very specific place which allows the re-entry of the current. That is called as the Wolff Parkinson White syndrome. That should not happen, but it happens in some patients. Then the conduction block is 3 degrees of severity of the AV block or the node. So atrioventricular block. AV block means atrioventricular block. See, first this 3 degrees, the first degree AV block. So these are the important terminologies we should learn in case of cardiac arrhythmias problem. The first degree block is delay in conduction from atria to ventricle. So the action potential is generated in the AV node and descending down into the this thing, especially the ventricle. And second degree block occurs when AV block is partial block in the atrioventricular conduction. Whereas the third degree block, so we may be many times when the cardiac the specialist they say that you have got the third degree block, etc. So this third degree block occurs when AV conduction fails completely, means there is a barrier in between the atrioventricular conduction. Maybe due to the myocardial infarction or the nerve damage or many more reasons are there. So the first degree block means it is just delay in the conduction. There is no block at all, but there is a delay. Whereas the second degree block, then it's partial. Here delay, here the AV block is partial, whereas it is totally blocked. So all these things. But in spite of all these things, in the case of cardiac tissue is such a what you call as intelligent tissue, it develops some other route to enter the conductions also. So types of arrhythmia, varieties of the arrhythmias are there. Not only one varieties of the cardiac arrhythmia, that's called as the tachyarrhythmia. Tachyarrhythmia means once again the atrial tachycardia means only the atrium is going to have the flutters, means more and more beats are there. Whereas the sinus tachycardia means SA node, there is only the especially in that particular node only, it is going to cause the block. Whereas the junctional tachycardia, so junction, AVA junction or there is a junction in between these two or imaginary anatomical locations are there. So here things are there. Then the supraventricular tachycardia means above the heart. This is said to be the cause of death of supraventricular tachycardia. Then ventricular tachycardia, then atrial flutters are there. The flutter means a continuous vibration. That's called as the flutter. Then paroxysmal tachycardia. Paroxysmal, just like the paroxysmal cough means there is a rest between two cuffs, paroxysmal type of the cuff. So the atrial fibrillation. So many these terminologies are there. Here only atria is going to fibrillate, means it is not the regular contraction. Fibrillation means vibration, especially whenever we have the electrocution, it is going to ventricular fibrillation. Is the most common thing that happens whenever if you touch the switch and there is no proper things, then we may suffer from the cardiac problem. Especially this happens in the this electric geyser is there in a home, then there is no proper thing at all, or the place is very wet, then the current flows from your hand and gets earth. So at that time, this is ventricular fibrillation occurs. The myocardium contracts arrhythmically. That's called as the ventricular fibrillation. So because of this thing, the deaths are going to happen, especially in case of electrocution, and also sometimes this thunderstorms are there. Then at that time, this is going to happen, the ventricular fibrillation. The cause of the death in case of electrocution is most of the time not only this fibrillation, most of the fibrillations, atrial fibrillations, many times the external current is going to generate numerous number of the impulses. So the animals are going to die. Then bradyarrhythmias. So this is tachyarrhythmias. Tachy means increasing. Brady means decreasing. So here bradyarrhythmia means there is a decrease in the impulse conduction or the contraction. That's called as the bradyarrhythmia. Then here the sinus arrest is there because the impulse will not generate at all. That's called as the sinus arrest. And sick sinus means there is a defect in the sinus or SA node or sinus. Then what happens is there is a sick in the arrest, especially then total AV block. So we have that so many blocks. So these are also the atrioventricular block. Then finally the cardiac arrest. The first one I have told but all these are very acute in nature. Whereas the other thing, the heart attack in the layman's terminologies are called maybe the coronary artery blockage, etc. Partial blockage, full blockage, etc. So it is heart attack. Whereas the cardiac arrest and heart attack are two layman's terminologies in which the yes we can explain. So Mr. Puneet Rajkumar has died due to the cardiac arrest. So there is very less time to get him admitted to the hospital or do some especially. Then skilled person should be available very fast. Whereas in such case, especially the heart attack or heart attack, then there is lot of time. Even there is here suddenly the heartbeat stops here. Totally the heartbeat totally stops, and if it stops for a minimum of 5 minutes, it cannot be recovered. Whereas here there may be heart tries to cope up with the body. It will never stop unless there is a great reason. So the coronary arteries are blocked and myocardial infarction are there. Then it is going to cause the heart attack. Heart attack means angina pectoris means lot of pain is there. Then there is a sweating, all these things are there. So this is the cardiac arrest and heart attack. A totally different term. So please try to differentiate between these two terms. But they are all the totally layman's terms, especially so we are talking in such terms, especially. Then here there is a small video is there.
Sinus rhythms originate from the sinoatrial node, or SA node. Atrial rhythms originate from the atria. Ventricular rhythms originate from the ventricles. Sinus rhythm is the normal rhythm of the heart set by its natural pacemaker in the SA node. In a healthy heart, the SA node fires 60 to 100 times per minute, resulting in a normal heart rate of 60 to 100 beats per minute. The most common variations of sinus rhythm include sinus bradycardia, when the SA node fires less than 60 times per minute, resulting in a slower heart rate of less than 60 beats per minute, and sinus tachycardia, when the SA node fires more than 100 times per minute, generating a faster heart rate of greater than 100 beats per minute. Sinus bradycardia and sinus tachycardia may be normal or clinical depending on the underlying cause. For example,
so you know the difference between
cardiac arrhythmias can be classified by site of origin.
So you should know the difference between the normal heart rate, bradycardia and tachycardia, which are the very, very basic things which need to remember by all persons, especially this
and sinus tachycardia, when the SA node fires. Bradycardia and sinus tachycardia may be normal or clinical.
So here, normal, bradycardia and tachycardia you should
depending on the underlying cause. For example, sinus bradycardia is considered normal during sleep, and sinus tachycardia may be normal during physical exercises. Cardiac arrhythmias that originate from other parts of the atria are always clinical. The most common include atrial flutter, atrial fibrillation.
Atrial, especially this rhythms means both left and right atrium.
And AV nodal reentrant tachycardia. These are forms of supraventricular tachycardia or SVT. Atrial flutter or A flutter is caused by an electrical impulse that travels around in a localized self-perpetuating loop, most commonly located in the right atrium. This is called a reentrant pathway. For each cycle around the loop, there is one contraction of the atrium. The atrial rate is regular and rapid, between 250 and 400 beats per minute. Ventricular rate or heart rate, however, is slower, thanks to the refractory properties of the AV node. The AV node blocks part of atrial impulses from reaching the ventricles. In this example, only 1 out of every 3 atrial impulses makes its way to the ventricles. The ventricular rate is therefore 3 times slower than the atrial rate. This is an example of a 3-to-1 heart block. Ventricular rate in A flutter is usually regular, but it can also be irregular. On an ECG, atrial flutter is characterized by absence of normal P wave. Instead, flutter waves or F waves are present.
So whenever there is atrial flutter is there, P is normal,
P wave
is absent.
Atrial fibrillation is caused by multiple electrical impulses that are initiated randomly from many ectopic sites in and around the atrium, commonly near the roots of pulmonary veins. These unsynchronized chaotic electrical signals cause the atrium to quiver or fibrillate rather than contract. The atrial rate during atrial fibrillation can be extremely high, but most of the electrical impulses do not pass through the AV node to the ventricles, again thanks to the refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate or heart rate is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow-QRS complexes. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atrium. In general, larger number of ectopic sites results in flatter baseline. AV nodal reentrant tachycardia, or AVNRT, is caused by a small reentrant pathway that involves directly the AV node. Every time the impulse passes through the AV node, it is transmitted down to the ventricles. The atrial rate and ventricular rate are therefore identical. Heart rate is regular and fast, ranging from 150 to 250 beats per minute. Ventricular rhythms are the most dangerous. In fact, they are called lethal rhythms. Ventricular tachycardia, or VTAC, is most commonly caused by a single strong firing site or circuit in one of the ventricles. It usually occurs in people with structural heart problems such as scarring from a previous heart attack or abnormalities in heart muscles. Impulses starting in the ventricles produce ventricular premature beats that are regular and fast, ranging from 100 to 250 beats per minute. On an ECG, VTAC is characterized by wide and bizarre-looking QRS complexes. P wave is absent. VTAC may occur in short episodes of less than 30 seconds and cause no or few symptoms. Sustained VTAC lasting for more than 30 seconds requires immediate treatment to prevent cardiac arrest. Ventricular tachycardia may also progress into ventricular fibrillation. Ventricular fibrillation, or VFib, is caused by multiple weak ectopic sites in the ventricles. These unsynchronized chaotic blood. VFib can quickly lead to cardiac arrest. P wave, QRS complex, or T wave. And
usually in case of this, especially tachycardia, the cardiac rate is totally disturbed. So sinus arrest, sick sinus and AV block, we know. Then coming to the antiarrhythmic drugs. So by this time we know what are the arrhythmia. So arrhythmia means rhythm is not proper, then the force of contraction or the time of contraction, etc. they are going to go. And coming to the especially the antiarrhythmic drugs, the number one, the the class 1 antiarrhythmic drugs, especially the sodium channel blockers. We know that sodium potassium ATPs is having very important role in case of this particularly. Then local anesthetic effect, especially the lignocaine etc. Then negative inotropic action, so the heart rate etc. they are decreased by the class 1 type of the drugs. And class 1A, these drugs are going to prolong the duration of action potential and also the refractory period. So for a very fraction of some milliseconds, the heart is going to be quiescent. So that's what is the prolonging the refractory period. Then inhibit pacemaker depolarization and AV conduction. Pacemaker SA node and AV conduction is going to decrease. So whenever there is arrhythmia, there is what as the force of this, especially the rate of contraction is increased. So then we have to reduce that particular the ionic current. And ventricular tachycardias and prevention of the paroxysmal recurrent, that's the atrial fibrillation. So that it will be stopped by the class 1 type of the drugs. Then class 1B, these are going to shorten the duration of action potential and the refractory period. So class 1B. Whereas the class 1C drugs are markedly decrease the rate of rise of action potential. So class C. So the class 2 drugs, especially they are beta adrenoceptor blockers, varieties of the drugs are there. And the third one, the potassium channel blockers. So we will see what are all the potassium channel blockers are there. So potassium channel is the one which is open during the depolarization process. Then it is going to later it's going to close. So these blockers we need to take because so the prolonged duration of action potential, then the refractory period will be prolonged. That's also one of the things it will be studied. So then another thing is use, especially these are used in supraventricular and ventricular tachyarrhythmias. In the ECG pattern, already we know that how to diagnose the different type of the cardiac arrhythmias. Then class 4 is calcium channel blockers. So we will see the examples of each and every category, discuss in detail about the drugs, especially, and the last category is the miscellaneous drug, which will not fall under any of these categories. So, okay, I will show you next. Then the classes of antiarrhythmic drugs are just like the once again this is a tabular form for the ease of remembering. The sodium channel blockers, especially these take the slope of the phase 0, the ascending phase of the phase 0 or height of the phase 0 is increased. Then can abolish the tachyarrhythmia caused by the re-entry circuit. So the second class is the beta blockers, then decrease heart rate and reduction velocity. And the third one is this can indirectly alter potassium and calcium conductance. So that's the thing. And whereas the potassium channel blockers, they are going to increase the action potential duration. That means the force of the contraction is going to increase to a greater extent. So then the action potential duration is abbreviated by APD. See here, or effective refractory period, or ERP. So the refractory period is going to be then inhibit the re-entry of the tachycardia. Then fourth category is calcium channel blockers. So these are going to slow the rate of rise in the phase 4. So calcium channel phase 0 and phase 1, you know, it starts from the opening in the phase 1 and later simultaneously the potassium channels are also open. And because of this thing, slowing of the rate of the rise in phase 4 then it's going to decrease the conduction of the velocity in case of SNO. So ultimately, we are going to have the, especially the antiarrhythmic activity. The class 1A, the classical example is the quinidine, class 1A drugs. So here the synchronamide is the one which is the source of the quinidine, and these are going to block or open the inactivated sodium channels, especially. Then block potassium channels. So what happens is if you block the potassium ion channels, in case of this cardiac action potentials, 50 millivolts. It starts from here, then goes suddenly, then curves up, then curves like this. So this is phase 0. 1, 2, 3. Once again, this is phase 4, and this is also for phase 4. So here the 1 and 2 and 3. So here the fast sodium channels are going to open. Then the action potential shoots up, then it goes to up to 50 millivolts. Then here the calcium ion channel starts, the sodium channels also start opening, then it's going to come down and later see resting membrane potential. So accordingly it is going to block the potassium ion channels. So here it is going to be blocked, especially the entire channel here. So instead of this is going to be this duration is reduced, so it's going to increase the duration of this axial potential. Then negative inotropic effect with the force of the contraction of the heart and the extent with the heart is going to reduce. Then it is also having some antimuscarinic effects. Then increased duration of the action potential and refractory periods of the atrium and ventricle is going to cause. This is the refractory period, means the heart stops for a while. That's a fraction of about 50 milliseconds. It's going to stop. Then it is going to increase the duration. So it's a class 1A drug, also the quinidine. Then procainamide is also another class 1A drug. The mechanism of action of both are similar. So ultimately, the slowing up of the rate of the rise in phase 0. So this is the phase 0. Already you have learned, and here this is the minus 85 or 80 millivolts. Suddenly it is going to increase, then it becomes a plateau, then it is going to come down. So here the decreased conduction velocity, especially the conduction velocity from the AV node to the His-Purkinje system, and decrease the V max, which reaches here the total max region of the cardiac action potential. So this is the maximum phase. So they prolong the muscle action potential, especially the cardiac muscles. Then class 1A drugs, slow phase 0 depolarization. This one is going to slow. Then prolonged action potential and slow conduction velocity. So that's how. Then they prolong the muscle action potential, and they are going to decrease the slope of the phase 4 reaction here. The phase 4 or the depolarization and repolarization time, and decrease the enhanced normal automaticity, or the normal automaticity will be decreased because of the all these combined effect. Especially they are going to block the sodium ion channels and also increase the zero phase. Especially. What are the ECG changes? There is a prolonged PR and QT and QT and the QRS complex, widening the QRS complex. So the gap between the QRS complex is going to widen. Then the drugs, especially the quinidine, is well absorbed orally. It's the oldest anti-malarial drug, and quinidine not. The well absorbed orally. Sulfate salt, quinidine sulfate, is absorbed more rapidly than the gluconate, especially in pharmacology. Highly bound to plasma protein. Most of the quinidine 6-1-alkaloid class of drugs are highly bound to plasma proteins. Then metabolized in the liver. So the metabolites are active. Then 20% is excreted and changed in the urine. Usually given as slow release formations, especially the RT or intermittent time. Preparations are there. Please get, I think you have brought this quinidine. So try to bring it and go and purchase. Usually given as slow IV, slow release of the formulation. Intravascular is most of the times highly painful. That's why the drugs, even including the anti-malarial drugs, are not given intravascular. So IV is, but it causes suddenly the hypotension is going to cause very slowly it will be administered in case of the patients. Then the clinical use of this procainamide or the PDD is used in the treatment of supraventricular arrhythmia, then especially in case of this both Parkinson-White syndrome, because it is a special channel is called and it's going to rearrange the receptor. And contraindication, complete AV block, whenever there is a AV block, may be due to so many factors, then intraventricular conduction, then defect, then myasthenia gravis, then hepatic impairment, all this will be, because this is going to be metabolized in the liver, so this should not be used in case of the persons who are having the hepatic impairment. That's also another thing. And adverse effects, the cardiac effects, then due to the antimuscarinic effect, especially the antimuscarinic properties will block the parasympathetic, especially M1, and the receptor type of they are going to block. So this is going to cause the ventricular tachycardia. Then syncope, sudden syncope may also happen. Whether you are administering the IV drip, then there is a chance. So that most of the time it's given for it. Then the QRS complex may be widened, AV block and acceleration of the ventricular tachycardia. And the another side effect is cardiac standstill, or is also known as the asystole, means the ventricle is not going to contract in a rhythmic manner. So there is a called as the sixth sinus. In the first one you have seen that the mild form of this action potential will be is generated by the sixth sinus and it's called as the sixth sinus syndrome. Then extracardiac adverse effects. So it's not a safe drug. It is not a safe drug. So it's having a lot of side effect and it's one of the most bitter drug also. So overdose causes the depression, hypertension, lethargy diseases, and another thing is called as the synchronism. So synchronalkaloids, they cause the headache, sometimes dizziness, then tinnitus means ringing in the ears, especially. Then also the deafness. So it's going to act on just like the aminoglycosides, they are going to cause all these things. The tinnitus means ringing type of the vibration type of thing. Then hypersensitivity reactions are also common, and also the hepatitis, thrombocytopenia are the very common side effect of the synchronalkaloids. So it's called as the synchronalkaloids. And diarrhea and nausea and vomiting are also very common, and it is having very bitter kind the metallic taste. It itself is highly toxic. So we should know all these side effects. And it may cause also certain drug interaction, the plasma level of the digoxin. Many times these need to be given simultaneously. Digoxin, especially if it is a congestive heart failure, so we are going to give the digoxin, which is going to cause sodium potassium, this ATPase in that. Then displacement of the tissue binding site is caused by the digoxin. This is also going to have the high plasma protein binding and decrease the digoxin renal clearance. If they are going to compete for the same site, then enhances the negative ionotrophic mechanism and hypotensive effects of beta adrenoceptor antagonist and calcium antagonist. So this also happens if you administer the calcium antagonist or calcium channel blocker, verapamil, etc., then propranolol, then they are having the negative ionotrophic action. So this is going to enhance. So all these things are beta adrenoceptor antagonists are going to block the beta adrenoceptor receptor, decrease the heart rate and decrease the force of the contraction. So the next drug, the class 1A category are the procainamide, as it's having the same type of the reactions to that of the this thing, especially the hypertension. So this is having less hypertensive, less antimuscarinic, less cardiotoxic procainamide, but it has got some of the other disadvantages completely absorbed after oral administration. It's also another thing. And can be given safely by intramuscular route. So try to procure this procainamide injection which is available in the market. Otherwise we will not be able to remember. And we see how we can use these drugs in the what we call as these cows are dying, especially in case of the foot and mouth. Because it is due to the cardiac fibrillation and the exact mechanism is not known. So we can use this such drugs, etc. We can see procainamide. So this can be used as IM or IV also. Then metabolize in the liver and give active metabolite which has class 3 activity. So class 1, class 2, class 3 and class 4 type of the drugs. Class 4 is this calcium channel blockers. So this procainamide is eliminated through the kidney totally, then more effective in ventricular arrhythmias, and is the second drug of choice after lidocaine in the treatment of ventricular arrhythmia. That's why most of the time the lidocaine is administered through IV to the calves, lignocaine or lidocaine. Lignocaine it's a local anesthetic, so it's going to block the sodium channels, and this is along with this second drug of choice, the treatment of ventricular arrhythmias. So suppose you have the electrocution, the drug of the choice to administer to is lidocaine. Suddenly if you touch some light and put the shot in the hospital, they are going to administer the lidocaine, very slow IV. Then effectively atrial fibrillation and atrial filters due to both Parkinson White syndrome. So this in this case also it's very common. So the first drug is quinidine, the second drug is the procainamide, and there are some pharmacokinetic properties. Always the drug, whenever it has an effect, it will have a side effect, binding of the QRS complex. So whenever you are administering these drugs, you always have to see the electrocardiographic pattern and inotropism, then the UV block, then also if you give this orally, then what nausea and diarrhea will be seen. And this toxicology, the pointers, which say very specific thing, and this is also there. Sometimes this hypotension is a very characteristic feature. So this is the pattern. That's the polygraphic pattern, ventricular tachycardia or toxicology OIDS. So they totally it is disturbed totally. Then the prolonged QT interval as well as this toxicology pointers. So class 1B are sodium channel blockers. So sodium channels artery blockers are going to act here, the rising phase of the entry of the sodium ions. Then shorten refractory period. So this includes the lidocaine, this the mexiladine, then procainamide, then phenidine, then amidine. So these are the classical examples of the class 1B drugs. Then lidocaine is the number 1 drug here. Shorten the duration of action potential and rating potential by shortening the repolarization phase here. It is going to shorten the repolarization phase in the particular disease. And the effective in ventricular arrhythmias, especially electrocution. So here in this graph you can see that class 1B drugs shorten the phase 3. Here, phase 3, because once again sodium ions are moving out and potassiums are coming inside this phase. So that's what is the repolarization phase and decreases the duration of the action potential here. This is what is the phase 3, this repolarization. So this effective respiratory period is going to be increased. Kinetic, well absorbed orally, especially only 3% general circulation orally. So whereas this lignocaine or lidocaine, this is very commonly used drug. If you suddenly administer the lignocaine, then it causes a immediate cardiac block. So orally if it is given, then only 3% is the general circulation. That's why these are always administered as very slow IV. If you administer it fast IV, immediately the animal is going to collapse. So always it needs to be administered as very slow IV preparation. Then, so other routes are not, if you administer this, the lignocaine IM, what happens? Lignocaine, the local anesthetic effect is got. That's why it is administered is slow IV, excreted by a kidney, half the IV is over. So whenever it is administered as why it is not given orally is only 3% is administered, whereas the therapeutic concentration cannot be attained. So many times that question is asked in the exams. So the therapeutic uses, this is one of the important drugs that need to be administered in case of the FMD induced cardiac problems. ventricular arrhythmias are present, acute myocardial infarction. So they are going to use this thing. As a compensation mechanism, what happens is in case of acute myocardial infarction, the heart starts beating very very fast and arrhythmia occurs. Then digitalis toxicity also, sodium potassium pump is inhibited, and this causes the especially the digitalis. In the case of congestive heart failures, to increase the force of contraction, we are going to increase the digitalis. So in this case also we need to administer the digitalis toxicity. And sometimes this, so yes, in case of sometimes whenever you are conducting some operations in the dog, then by overcharge, this thing you might have injected more and more anesthetic. Then it may cause the cardiac block. At that time we need to administer the drug, especially anesthesia. Open heart surgery. So suddenly, if you cut the heart and everything, there is a chance that the heart is going to block. Then at that time, we need to administer the drug, especially in case of the lidocaine hydrochloride or lidocaine hydrochloride. Both are same. Adverse effects are the neurological effects. Chondrite is having some side effects. Okay, open heart surgery, another thing. Neurological problem contraindicated in epileptic, then arrhythmias are uncommon, then hypotension is due to cause, then effective oral, yeah, so some this, especially if you want the oral drugs, that's called as the mexilatin. Mexilatin is available as the tablets, and you can use this. And effective orally, half-life 8 to 20 hours. That's also one of the good indication. In case of coughs, you can administer this mexilatin, ventricular tachycardia. Then use in chronic treatment of the ventricular arrhythmias, effective in relieving chronic pain due to the diabetic neuropathy and the nerve. Adverse effects of this drug, is neurological side effect, contraindicated and causes the bradycardia, conduction, especially defects, then this hypotension, hepatic failures, and also the myocardial failures. All these things. Whereas the class 1C, most potent sodium channel blocker, and the rate of the rise of the action potential here, action potential is right, 50 to 50. So the drugs are the glycanidine, then propafenone, then molicizine, then anaconide, then indecanide. So these are the drugs. Please remember the drugs, especially few of the drugs are very commonly used drug in this category. Then the first one, that's the glycanide, no effect on the duration of action potential and active potential. So in such case, it's not going to cause no such side effect. The ability to depend, especially the depressed, especially the conduction and velocity. Then approved for refractory ventricular arrhythmias as pro-arrhythmic effect is also there. You need to see all such conditions. Then so class 3 drugs, how they are going to act is markedly slow the phase of zero of the depolarization. So they are going to decrease the phase 0 here of the depolarization. Suppose this is the phase 0, then when there is no drug, it is going to be very steady. Whereas if you administer a drug, then the slope is going to increase, especially in 0 phase. And propafenone has a weak beta blocking effect used to maintain. Please check all these things in case of SIMS. Get these drugs so that we can remember, or else it's very difficult to remember any of these drugs. And adverse effects, the metallic taste and constipation. If you take this, especially the drugs like the metronidazole, and I think it is having a lot of metallic taste and sometimes this bitter taste in the tongue. That's how it's causing at the same time the adverse metallic taste and constipation. So there is a comparison chart is there in between the classical phase, especially class 1A, 1B and 1C. So you know the examples of class 1A are quinidine and procainamide, whereas the class 1B, you know the examples. And example, the sodium channel blockers, especially the flucainide, etc. Here the examples are also there, quinine, then the moderate, so lidocaine. So whenever you cannot administer this lidocaine, you can go for the flucainide, etc. So here there is a change, the shift in the right from as the shift in left. So this is class 1 way. If you administer the quinine, it is going to shift the curve to the right as far as possible. Whereas it is not changed in the class 1C. So accordingly you can extrapolate the results. So whereas the class 2 drugs, they are called as the antiarrhythmic drugs. These are the beta adrenergic blockers. So already you know very well about the beta adrenergic blocker. So here the mechanism of action is negative inotropic and the chronotropic action is seen. Then it is going to prolong the AV conduction, that's delay in the artery, and diminish the phase 4 repolarization. So see this phase 4 is the repolarization. Then the automaticity of ectopic focus. The user's treatment of increased sympathetic activity induced arrhythmias such as the stress and exercise induced arrhythmias. So this can also be used. Suppose arrhythmias are due to the stress at the same time. Then stress means too much exercise stress or something this post stress. Then atrial flutter and fibrillation. Then AV nodal tachycardia, reduced mortality in post myocardial infarction. So these are the drugs. And protection against sudden cardiac death, maybe in case of pre-transplant case. So cardiac arrest. So such drugs need to be administered. So depending upon the severity, in such case, if you administer such a drug orally, then it's going to be absorbed very slowly. So we have to go for the very fastly acting drugs, IV drugs. So propranolol is one of the non-selective beta 2 adrenergic blocker. So you can need. So to reduce the incidence of sudden arrhythmic death after myocardial infarction. That's one of the drug of choice, propranolol. And metoprolol, so you have studied all the pharmacokinetic property of this drug in the autonomic nervous system. Metoprolol can reduce the risk of the bronchospasm. They are non-specific. Both beta 2 type of the adrenergic receptors are also present on the bronchial and it's going to dilate the bronchial. So there is bronchospasm is going to cause. So then esomolol. Then esomolol is a very short acting beta 1 adrenergic blocker that is used by intravenous route only in acute arrhythmias occurring during the surgery or emergencies. Maybe emergencies like electrocution, etc. Esomolol can be used. So being a cardiac expert, so you can use such drugs. So beta 2 adrenergic blocker. Please remember the number 1 drug is propranolol. The number 2 is metoprolol or esomolol. And apart from this one also some newer drugs are also there. These are the last 3 drugs are potassium channel blockers. The drugs that prolong the duration of action potential here, the duration refractory period. So supraventricular and ventricular tachyarrhythmias can be used. So the class drugs prolong phase 3 depolarization here without altering the phase 0. Phase 0 will be there same, whereas the phase 3 is increased. So antiarrhythmic drugs are the potassium blockers. It prolongs the phase 3 without any affecting the phase 0. That's the characteristic feature. And they prolong both the duration of the action potential and ERP. So their mechanism of action still it is not clear, but as we can guess that the potassium channel is active throughout the phase 1, 2 and 3 and always the resting membrane potential. So class 3 the examples are the sotalol, then amiodarone, then albuterol. These are the classical example of the class 3 type of the drugs which are the potassium channel blockers. So remember this sotalol. So the users of this drug are antiarrhythmias associated with the Wolff-Parkinson syndrome, then ventricular arrhythmias, especially the ventricular fibrillation and tachycardia. And also the supraventricular tachycardia is there, supraventricular tachycardia. Then amiodarone is limited due to its wide range of side effects, so it's not having the correct effect. So whenever you administer the potassium channel blockers, there is a chance that they may hinder the actual, especially sodium electrolyte and electrolyte imbalance may be also caused. The sotalol or is many times the sotal core is also called. So prolongs the duration of AP, action potential, and sotalol suppresses the phase 4 or spontaneous depolarization and possibly producing severe sinus bradycardia. Sinus bradycardia means the action potential generation itself is going to be reduced. That causes the sinus bradycardia. So because of the beta blockade action, it's having non-specific action. Then another drug is ipodalite used in the atrial fibrillation or flutter, and only this use is the IV administration may lead to torsade pointers. That's the total derangement in the quick resting waves, and only drug in class 3 that causes pure potassium blockade. So this is not having any other non-specific binding like this. It's not having the beta blockade action. Then the amiodarone medication is very commonly used in case of this ventricular tachycardia or tachycardia. Then it is going to, it's a very having antiarrhythmic effect. It is having the repressing of all these property 1, 2, 3, and 4 actions, but predominant inhibitory effect on the potassium channels. So it slows the cardiac correction, works as potassium channel blockers and as a weak beta alternative blocker, and inhibition of the inactivated sodium channels. And it can be used both the parenterally and orally. Amiodarone is a drug of multiple actions. So it has got the 1, 2, 3, 4 actions. So many times this is very frequently administered by the physicians. It is metabolized here, and the T half is 60 days. This is very, very important. So the potent is a P450 inhibitor. Then dominant effects are prolongation of the action potential duration and refractiveness used in the supraventricular and ventricular tachyarrhythmias. So the toxicity is also very common. So toxicity is common, and the common toxicity signs are the GI intolerance, tremors, ataxia, dizziness, and hyper or hypothyroidism. So it's going to artificially induce the iatrogenic hypothyroidism. Then corneal micro deposits may be accompanied with disturbed night vision is also seen. So liver toxicity, then photosensitivity, gray facial discoloration, prolonged use, neuropathy, muscle weakness, and weight loss may also be seen. And this property, toxicity of this thing is used for the weight lossing purpose, especially in case of certain person, this obese person. So, but ultimately it has a lot of side effects. Then most dangerous side effect is pulmonary fibrosis, which occurs in 2 to 5% of the patients. So this is a misused drug, especially for reducing the weight. That's why all these side effects are known, because when it was misused by the persons who are present in the gym, etc., then pulmonary fibrosis, which occurs, which is irreversible in nature. And last is the class 4 drugs, the calcium channel blockers. The examples are the verapamil and milidalzane. So main site of action is AV node and SA node. So effective only in atrial arrhythmias. If it is a ventricular arrhythmia, then it is no use. So here class 4 drugs, slow phase 4 type of the spontaneous depolarization issues and depend on the calcium currents. So it is going to decrease. Then here you can see that phase 2 is totally depressed, whereas the AV node is going to low. Then second drug of the choice of treatment is paroxysmal or the supraventricular tachycardia. Especially then no effect on the whole Parkinson-White syndrome, because it is only this type of the effect. The action potential need to pass through the ventricle. but it's not having. Okay, and here it's going to act this place on the phase 1. That's why it's not having any action on the ventricular tachycardia. So such type of the catchy term you have to write and remember. The verapamil is one of the drug, a characteristic calcium channel blocker. So vascular smooth muscle is going to be relaxing. Then suppress automaticity of the SA node. High first pass metabolism if it is given orally. Then this hepatobiliary destruction. The side effects: hypotension, sinus bradycardia, and the cardiac depression is also seen. Then high dose EV block, cardiovascular collapse, sudden collapse, syncope is there, and contraction, this contraindication, myocardial failure, EV block, then bradycardia, severe congestive heart failure, it's also not indicated, and glycoside toxicity. So uses supraventricular tachyarrhythmias, then atrial flutter and fibrillation. It is used very commonly, but not in case of the ventricular tachycardia. That's important. And DGTSM is another this congener of this calcium channel blocker. Mode of same is just like calcium channel blocker. Here the calcium channel is open, then but less potent when compared to the verapamil. Verapamil is non-specific, whereas this is little specific. So this produces the peripheral vasodilatation, negative endotrophic effect, etc. The side effects: bradycardia, constipation, then lethargy, then contraindication, AV node, conduction, disturbances, bradycardia, impaired left ventricular function, then hypotensive in case of patients. So uses atrial fibrillation, hypertrophic cardiac myopathy, then hypertensive atrial flutter, and fibrillation is there. Then angina pectoris is also another common feature. So here you can see class 4 drug flattens the flat tube and slows the conduction of these tissues here. Whenever there is no drug, then this is the drug. It's going to decrease the flow and slow down the conduction, especially in the AV node. So AV node and SA node is a conduction. So this is the, whenever there is a no drug is there, especially in the ventricular tachycardia, when it is administered, when class 4 drug is administered, it is going to decrease. Because here the calcium channels are open, then it causes the, so here total calcium channel is blocked, then it is going to reduce. So this is the summary of totally what happens on the heart, especially class 1 A vinidine. The thing is, we need to remember this thing. Class 1 A vinidine and propanamide. Class 2B lerodine. Class 1C, especially that's flecainide. And class 2 propanol. Then class 3 amiodarone. Then class 4 verapamil. This is the important thing you need to remember forever, and all these things need to be remembered. Whatever happens, there is totally it's going to decrease the cardiac rate and conduction. So these miscellaneous drugs or last class of the drugs are adenosine. It's bind to specific G protein coupled receptor and coupled adenosine receptor, A1, A2 opening up of the potassium channels, and ultimately it causes the hyperpolarization. Then reduce the influx of the calcium. So the adenosine, of course, it is less commonly used, and only very specifically when it is required, it is going to be used. Whereas the amiodarone is one of the very commonly used drugs. Then the pharmacokinetic, very rapid onset of the action, then short half-life, especially the adenosine given only IV, rapid IV bolus injection, whenever there is a complete stop of the heart, especially are very fast, and for acute mental termination of the re-entrant. So that's the drug of the choice. So whenever you are administering the drugs acting on the cardiovascular system, you have to be very, very careful, and you should know the mechanism very properly, or else you may cause the death of the patient. And bronchial asthma should not be used, EV block, hypotension, etc. Magnesium digitalis induced arrhythmias. So if you administer this magnesium sulfate fast IV, it is going to be used as anesthetic agent. And toxicology pointers, it is used. And sinus tachycardia is also going to be used. And potassium sometimes used in the digitalis induced arrhythmias. Whenever there is a congenital heart failure, we are going to use this digitalis, then it's going the arrhythmias. Then how antiarrhythmic drugs work is there, especially how they are going to basically video is there. I will show you later. So this is about the antiarrhythmic drugs. And in the next class we are going to, especially whenever there is high BP or the anti-arrhythmic drugs is over, and we will see the other classes of the drugs as per the syllabus. And please prepare this PPT because we need to know how this can be used properly.